The tumors of the cellular migrants to the skin are the tumors in which the progenitor cell arise somewhere else and then they specifically reside in the cutaneous microenvironment. Two important group of lesion in this category are cutaneous T-cell lymphoma and mastocytosis. The important one in cutaneous T-cell lymphoma is mycosis fungoides. Cutaneous T-cell lymphoma is a term that is applied to a spectrum of lymphoproliferative disorder that affect the skin and they have got many distinctive presentations. 80% of cutaneous lymphomas are T-cell lymphomas while 20% are B-cell lymphomas. The tumor cutaneous lymphoma is applied to term especially the cutaneous T-cell lymphoma. This is applied to the tumors that first manifest on the skin and later as the neoplastic process involves the entire lymphoproliferative system, they are going to affect lymph node internal organs later in their course. The most classic form and most common form of cutaneous T-cell lymphoma is mycosis fungoides, and the origin of this is helper T cell, CD4 helper T cells. Mycosis fungoides is the lymphoma of skin homing T helper cells that presents in the skin. The condition is uncommon, but it is not rare, and the extent of the lesion varies from a localized lesion of the skin that persists for years and then develop as systemic lymphoma. This condition is more common in men, being twice as common than in females. Any age group can be affected by mycosis fungoides, but it is common in the people with age more than 40 years, and the median age for this lymphoma is 55 to 60 years. The commonly affected site is truncal area such as lower abdomen, buttock and upper thigh, but may occur at any site. Main differential diagnosis is from psoriasis, parapsoriasis and fungating eczematous nodule. It preferentially affects black over white. The mycosis fungoides remain asymptomatic or present with severe itching that is hard to control. The case of the mycosis fungoid can be misdiagnosed for months and years as psoriasis, nummular dermatitis, and large plaque parapsoriasis. Parapsoriasis is a term used for well-defined erythematous scaly patches and plaques that are present as digitate pattern on lateral border of trunk in middle-aged man. Lesion of the mycosis fungoides are divided into three stages: patches, plaques, and tumor. It is possible to encounter more than one lesion at a time. Actually, the disease is divided into three stages representing the uh, lesion. These are pre-mycotic, mycotic, and tumorous. The term plaque is used for skin lesions that are elevated, solid, and these are superficial lesions and typically more than 1 centimeter in diameter, while a patch is a large area of color change with a smooth surface. The pre-mycotic or patch phase may present for months and consist of eczema-like or psoriasis-like lesions that are scaly erythematous macules that may be slightly indurated. As I have earlier stated that these lesions involve trunk, lower abdomen, buttocks and upper thigh and also affect breast in women. In the mycotic stage, There is a raised indurated plaque, and this is irregularly outlined and erythematous. They may coalesce and involve large areas. Finally, in the tumorous stage, what happens that there is onset or appearance of multiple nodule of variable sizes, and they can appear on the plaque or apparently on the normal skin. So in pre-mycotic stage, there is no nodal or visceral mat, and mycotic is late stage, while tumorous stage is associated with may be associated with systemic spread. The lesion of the mycosis fungoides are randomly distributed. They may be scaling or non-scaling patches in different shades of red. Here in this picture, there are patches and plaques both present, and some are showing confluence. Some areas are showing scale formation also. Initially, diagnosis of dermatophytosis was made, but a negative result of potassium hydroxide preparation excluded the dermatophytosis. Then patient was treated for psoriasis for 2 years and was unresponsive for the psoriasis treatment. Then the mycosis fungoides was confirmed on biopsy. The lesions are well or ill-defined. At first they are superficial. They are much like eczema or psoriasis. They may mimic dermatophytosis as we have seen in this last picture, and later they become thicker. This photograph, gross picture, is showing patches on the back. They have got irregular border. Some are scaly and some are non-scaly, and they are displaying various shades of red. Mycosis in this name, mycosis fungoides, is derived from the fact that these lesions mimic dermatophytosis. A skin plaque is an elevated, solid, superficial lesion that is more than 1 centimeter in diameter. A round, oval, archiform, annular, or bizarre plaque can be present. These are randomly distributed, but in early stages often spare exposed surfaces. This picture we have seen earlier. There are many irregularly, randomly distributed, well and ill-defined patches and plaques. This is another picture, and this picture is showing there are many crusted plaques along with nodular areas. Some nodules are flattened. The late lesions of mycosis fungoides show nodules that may or may not show ulceration. This picture is showing plaque in early nodular stage with reddish brown scale and crusted plaque and flat nodules. Here, lesions are scaly, crusted, eczema-like plaques on the arm and chest. These have turned nodular on the shoulder, and a few on the arm also turned into nodules. There is another tumor presentation. Here, this nodular or tumor stage of mycosis fungoides is showing two mushroom-like lesions that are present on the leg, and they are showing ulceration. Extensive infiltration can cause leonine or line-like faces, as evident in this 50-year-old patient who developed pruritic generalized eczema-like plaques on trunk. That was treated for 4 years as eczema, and later the nodule of facial infiltration resulted in line-like phases. Confluence of lesion may occur and lead to erythroderma. Palmar and plantar keratosis may also develop, and there may be presence of hair loss. Poikiloderma, that is presence of telangiectasia, reticulate pigmentation, atrophy and loss of pigmentation. It may be present from the start of the disease, or it may develop later in the course of the disease. This is the gross appearance of early stages of mycosis fungoides. Here, there is erythematous scaly patch and plaque. These are present with irregular boundaries. There is telangiectasia, atrophy, and pigmentation also. In this gross picture, there is scaly erythematous patches that have got irregular borders, and many of these patches and plaques have become confluent, and these are present on the trunk and buttock area. In this gross appearance of mycosis fungoides, there is a presence of infiltrative plaques all over the body, and scaling is also present in some areas. This gross picture is showing several erythematous plaques with scaling and ulceration, and they are distributed throughout the body. 5% of these mycosis fungoides progress to a more severe aggressive form, and that is termed as Sézary syndrome. This syndrome we will discuss in detail at the end of this topic. The cutaneous T-cell lymphomas are characterized by clonal proliferation of the CD4 plus helper T cells. These cells express cutaneous lymphocyte antigen, hence they home to skin. These lymphomas are associated with many oncogene and tumor suppressor gene mutations, but none is specific to it. Tumor cells have clonal tumor cells have clonal T cell receptor gene rearrangement, or may sometimes show aberrant combination of T cell surface antigen. Some scientists also suggested that this is related to viral etiology. The histologic hallmark of mycosis fungoides is presence of atypical cells that form band-like aggregate within the superficial dermis and epidermis, and they invade epidermis singly or in the form of groups. Mostly the cells are cutaneous T lymphocyte antigen positive, CD4 plus, but lesions of mycosis fungoides can show CD8 plus or cytotoxic lymphocytes also. These cytotoxic lymphocytes are considered to reflect antitumor response by the host. The group of lymphocytes in the epidermis are termed as Pottier's microabscess. Some scientists claim that this was first described by Derrier, and in some French literature, these are termed as Derrier's microabscesses, but the term mostly used in literature is Pottier's microabscess. The nuclei of these cells show markedly infolded nuclear membranes that impart it appearance, an appearance like cerebrum, hence termed as cerebriform nuclei or convoluted nuclei. The gross lesion of patches and plaques show epidermotropism. This is due to expression of adhesion molecule, cutaneous leukocyte antigen, and chemokine receptors 4 and chemokine receptor 10. In the nodule, this epidermotropism is lost, and there is local and systemic spread of the disease. This photomicrograph is showing that there is presence of many atypical cells that are homing within the skin, within the epidermis. This photomicrograph is showing the epidermotropism by neoplastic cells in mycosis fungoides. In the initial stage of the disease, the appearance may be non-diagnostic and mimic a chronic non-specific dermatitis. Later, in the mycotic stage, infiltrative plaques show polymorphous inflammatory cells in the dermis uh, with a small number of atypical lymphoid cells. These cells may form a band-like infiltrate that is present along the epidermal basement layer, and they may go to the epidermis and form Potter's microabscess. Presence of band-like infiltrate in the absence of spongiosis is highly suggestive of mycosis fungoides. In the tumor stage, the dense infiltrate of atypical cell expand the dermis. This picture is showing the nuclear atypia and convolutions characteristic cerebriform appearance that is seen in the mycosis fungoides, and presence of these cerebriform cells confirm the diagnosis, but this is not pathognomic of the mycosis fungoides, as similar cells are present in other forms of lymphomas and acute and chronic dermatitis also. In this photomicrograph, there is atypical infiltrate of lymphocyte, and this is expanding the superficial dermis, and the tumor cells are extending into the epidermis, that is termed as epidermotropism. In this photomicrograph, the arrows are pointing towards atypical nuclei, and these atypical nuclei are showing cerebriform appearance. The nuclei are hyperchromatic and convoluted. This is the Sézary cell or atypical lymphocyte that is present in the peripheral smear of and this is seen in the leukemic phase of cutaneous T cell lymphoma or mycosis fungoides. There is convolution of the nuclei that is prominent. Besides biopsy, other investigations that are helpful are blood picture that shows eosinophilia, and it can range from 6 to 12% and can increase in some cases up to 50%. The Buffy codes show abnormal circulating T cells. WBCs are increased and may go up to 20,000 per microliter. Bone marrow examinations are not helpful in early stages, and blood chemistry revealed LDH lactate dehydrogenase 1,2,3 isoenzymes elevation in erythrodermic stage. Chest X-ray is helpful in identifying hilar lymphadenopathy, while imaging such as CT, gallium scintigraphy, liver spleen scan, and lymphangiography are not helpful during early stages, but in later stages these are helpful, especially in case of advanced disease. They are helpful in searching for the retroperitoneal nodes. Diagnosis of mycosis fungoides can be made on obvious clinical lesions, but histological confirmation may not be possible for years despite repeated biopsies. Immunophenotyping of infiltrating T cell by use of monoclonal antibodies, T cell receptor rearrangement studies are important for diagnosis of the disease. However, the lymphadenopathy and detection of abnormal circulating T cells in the blood correlate well with the internal organ involvement. The differential diagnosis of this disease is mainly from other diseases that show scaling plaques. A strong suggestion or suspicion arises in patients who have got refractive psoriasis, refractory eczema, and poikiloderma. So the skin, blood, and lymph nodes of a suspected patient should be evaluated meticulously. In the skin, the body surface area assessment, routine histology, immunophenotyping, and polymerase chain reaction for T cell receptor rearrangements. In blood, complete blood count with smear examination and immunophenotyping is necessary, while lymph node examination should be done for all lymph nodes of the body, measure enlarged nodes by CT scan, and biopsy of the enlarged lymph nodes. This is the staging scheme for the mycosis fungoides that is proposed by International Society for Cutaneous Lymphomas, and the T that denotes tumor is T1 is for patches, plaques, or both that involve less than 10% of the body surface area. T2 is for the lesions that affect 10% of the body surface, and T3 one or more cutaneous tumors, while T4 is for development of erythroderma. The nodal involvement, if there is no involvement, that is termed as N0 when the clinically palpable nodes are there, but histologically these are uninvolved, it is N1. When clinically these are not palpable and histologically involved, these are termed N2, while lymph nodes clinically enlarged and histologically also involved are termed as N3. When there is no visceral disease, it is M0, while visceral disease presence is denoted as M1. When no circulating atypical cells, the Sézary cells, are present, it is termed as B0, while B1 is presence of circulating Sézary cells. On the basis of these characteristics, the disease is staged from stage 1A to stage 4B. The prognosis of mycosis fungoides is unpredictable, and this pre-mycotic phase may be present for years. Median survival time is variable for mycosis fungoides. At NIH, it was calculated 5 years from the time of histologic diagnosis, while in Europe it was calculated about 10 to 15 years after the diagnosis, but the vast difference may be due to selection of the cases. The patient less than 50 years of age have twice the survival rate of patient than patient who are more than 60 years of age. The indicators of bad prognosis are tumors presence, and in these cases the mean survival is about 2.5 years. Presence of lymphadenopathy, in these cases the mean survival is about 3 years. Another bad prognostic indicator is the skin surface involvement with pre-tumor stage that is more than 10% of the body, and generalized erythroderma. Now the treatment of mycosis fungoides. The treatment is symptom oriented and depends on the extent and stage of the disease. In the pre-mycotic or pre-mycosis fungoides stage, when the histologic diagnosis is compatible and it is not confirmed, poor photochemotherapy or narrowband ultraviolet B therapy can be given. In early cases of the disease, that is histologically proven, but there is no lymphadenopathy and no circulating T lymphocytes are present. Psoralen plus ultraviolet A photochemotherapy is the method of choice. It may or may not be combined with the oral isotretinoin or bexarotene or subcutaneous alpha interferon. The side effects of isotretinoin are hypothyroidism, increased triglycerides, abnormal liver function test, glucose abnormalities, and neutropenia. When the limited body surface is involved by the disease, topical chemotherapy with nitrogen mustard in an ointment base, 10 mg per deciliter, topical carmustine can be given with a total body electron beam therapy. Isolated tumor can also be treated by local X-ray or electron beam therapy. For cases of advanced stage in which there is extensive plaque presence, multiple tumor presence, lymphadenopathy, and abnormal circulating T lymphocyte, electron beam plus systemic chemotherapy is used, while the patients that are unresponsive to treatment are the candidate for allogenic stem cell transplantation. The 5-year survival rate for these patients is 75%, while quarter of patients die from stem cell transplant complications.